have everyone inch forward a little bit? This is a huge room for a break shop, and we really want to engage you all. So this is the Global Surgery Engagement Opportunity, APSA and ACS Partnerships for Pediatric Surgical Education Break Shop. We're really happy to have you all here. I know it's the end of a long first day, but I just want to start by introducing our panel here, and some of our panel is also abroad internationally, so I'm just going to introduce everyone. Our first speaker is Dr. Robin Petrozzi. She's an associate professor in the section of pediatric surgery at the University of Michigan and Mott Children's Hospital. She's the vice chair for global surgery for the University of Michigan Department of Surgery. Also joining us on our panel today, next to Robin, is Muriel Cleary. She's an assistant professor of surgery and pediatrics at UMass. She's been an integral part of the American College of Surgeons Hope Hub development in Lusaka, Zambia, at the University Teaching Hospital and University of Zambia. She will be joined by a colleague and partner in Lusaka, Dr. Eamon Gongola, who will be presenting to us on a pre-recorded video. And then next to Muriel is Dr. Haren Baumgarten. She's a pediatric surgeon with the Western Surgical Group in Reno, Nevada. And she's been amongst the first pediatric surgeons working at the American College of Surgeons Hawassa Hub in Ethiopia. She will be joined by a colleague and partner, Dr. Wande Woldesenbet, a pediatric surgeon at Hawassa University. Thanks again for joining us.
Okay. So, again, please feel free to write down questions. We're hoping to leave some time. None of the speakers have any disclosures. So a little bit of background. The American College of Surgeons' international efforts sat with the International Committee as well as Operation Giving Back, which focused a lot on humanitarian outreach. In 2016, similar to many institutions, ACS reevaluated its global engagement and shifted some of its humanitarian and volunteerism focus to developing more hands-on programming, specifically working on capacity development through partnership with international surgical societies. The College of Surgeons of East Central and Southern Africa, COSEXA, was identified as a first partner. ACS and ABS have partnered for examinations and training and education as a society. And they identified, after multiple site visits, a site in Northern Africa at Hawassa University in Ethiopia, and in Southern Africa at the University Teaching Hospital in Lusaka, Zambia. An additional site for trauma management was identified in Rwanda later. The program is structured through a hub or a consortia of participating universities and hospitals at each site. So there are about 12 to 13 mostly university programs that partner at each site. What both sites recognized early on when you're looking at training surgeons in low resource settings, but particularly in the countries where COSEXA is working, is that greater than 50% of the population are children. And so a lot of times if you're training general surgeons, a lot of what they're doing and a lot of the need is in pediatric surgeons. And so at the first work plan meetings, prior to any of their site visits, APSA was asked to partner with the American College of Surgeons in 2019, and so this has been a long process to build this partnership. And just to recall that the APSA Global Pediatric Surgery Committee, when we look at the mission and how that fits within APSA as an organization, some of that mission is to develop partnerships with overseas colleagues to facilitate the exchange of information and resources. A lot of that through educational programming, NAT being available free or at low cost. To advocate and encourage responsible international service and surgical education by APSA members and trainees, to facilitate those educational opportunities of surgeons that are caring for children in resource-limited settings, identify and support areas of research relevant to pediatric surgical care in resource-limited settings. And so this opportunity, while not inclusive of all of the partnerships or areas of the world where APSA members participate, we saw as an opportunity to really engage and work on our vision of promoting access to optimal surgical care for children throughout the world, and really identifying partners for that. It was seen as something responsible. It's very locally driven, hopefully sustainable. One of the things that's a challenge when you're an organization that has rotating committee members is how do you make that a sustainable effort that doesn't change throughout time, that really impacts capacity, and really answering the call from APSA members, I want to get involved. How do I get involved? And so we developed a memorandum of understanding. Again, this is a process that was signed in the spring of 2021. And that mission is that APSA seeks to further the mission of academic and educational capacity building partnerships supported by the American College of Surgeons with a focus on addressing the training needs for the care of children. Again, recognizing that children are not little adults and that a large percentage of what general surgeons and GPs and increasingly pediatric surgeons in many places around the world are doing is really addressing children's surgical care. The goal is to recruit APSA member pediatric surgeons as volunteers to augment the existing partnerships through the ACS Hope Collaborative. And there are various ways to be involved in clinical care, teaching, program development, training, mentorship. Our plan was up to 4 times a year to have pediatric surgeons augment what's already happening through the hubs. Additionally, to contribute to the curriculum development related to the specific surgical and perioperative management in children and neonates. Again, this falls within what APSA does very well. The goal, again, was to augment the training initially of the general surgery programs that the college was partnering with, but increasingly recognizing the needs of the local pediatric surgeons for their program development. That the Global Pediatric Surgery Committee would provide mentorship to vetted pediatric surgeons participating in the program. People want to participate, they don't always know how or what to expect. Our goal was to set something up so that we could do that. In exchange, the American College of Surgeons will provide the local logistics for APSA member participants. Essentially the same as what any of the partners through the consortia of surgery programs. So that includes local housing, in-country transportation, assistance with local medical licensure, orientation, things to facilitate the needs so that we're not having to set up something new. It is still a volunteer opportunity, so anything in terms of your local malpractice, your own personal malpractice, time away from work, transportation is still a volunteer opportunity, but we felt that people would want to participate if we could handle some of those on-site logistics. So it's been a process to get this initiated that's taken quite a few years, but what this session really wants to do is to start recruiting APSA member pediatric surgeons. We're ready to go live, and we want to tell you about the partnerships and the opportunities in Hawassa, Ethiopia, and in Lusaka, Zambia. And so I'll turn it over to Muriel to talk about Lusaka.
Thank you so much for the opportunity to share some brief overview about the surgical training program in Lusaka, Zambia, and our hopes for an APSA collaboration. So Zambia is a beautiful landlocked LMIC located in central southern Africa. It's a stable democracy, which fortunately has not been subject to significant political or environmental turmoil over recent years. The population approaches 20 million, with nearly half of those individuals being children. In the capital city of Lusaka, it's very accessible. There is an international airport, about a 35 to 40-minute drive from the hospital, in which UTH, or University Teaching Hospital, is located. It's the major tertiary referral hospital. And the campus also includes the University of Zambia Medical School, the School of Public Health, there's a nursing school, and a number of training programs located on site. There are additional capacity for pediatric surgery in one other smaller hospital in Lusaka and one in the north in Ndola. So the pediatric surgical training program was first begun in 2015. There are currently 10 trainees in various levels of training and 2 senior consultant pediatric surgeons for the region. You'll be hearing from one of them, Dr. Aman Nangola, who will be sharing a video of his experiences and many more details about the program. They also have 3 recent graduates from the program. So Dr. Ngola was the first graduate from this program and stayed to further develop it. And they have 3 recent graduates who are currently serving as junior consultants. There are 3 dedicated pediatric ORs, so shared with other surgical subspecialists. These were donated actually by Kids OR in 2021, so are relatively new. There are 3 full-time pediatric anesthesiologists, and this is a new development. They had 1 for a very long time, full-time, and 1 who was part-time. And just as of last year, they have developed a new training program in pediatric anesthesia. And that's one of the major resources where they have been limited in the amount of surgery that they can do. So this will hopefully bolster the volume that they can support. They have a 90-bed NICU with only 2 functional ventilators currently. There are 2 higher acuity rooms in their NICU. Each can house about 5 patients, so a capacity of about 10 higher acuity patients. In general, there is very limited access to basic surgical supplies, equipment, access to intensive critical care, and quite limited access to radiology, to laboratory studies, to timely pathology. As part of the ACS Hope collaboration, UMass was one of 9 institutions participating and rotating through in an attempt to create a sustainable curriculum to support the various training programs. There are 4 pillars identified and collaborative work groups in clinical, education, quality, and research. A lot of my work was leading some of the research endeavors and creating a virtual curriculum, a structured mentorship program, as well as research in progress meetings to support their research interests. And I had the opportunity to give didactics and lectures and support some of the surgical skills and simulation workshops. But one of the main priorities really is aligning our capabilities with the interests of the pediatric surgeons there and supporting their many ongoing initiatives. So over the course of 3 site visits, the first in October of 22, then March of last year, and more recently in February, I had the opportunity to observe an extremely vibrant and engaged training program with really dedicated mentors and a true vision, as you'll see soon, for expanding surgical capacity for children, not just in Lusaka, but really across the entire country. This is just a kind of overview of the structure of their week and the day-to-day work. They do have OR time 3 days a week, Mondays, Wednesdays, and Fridays, and they share this space with a pediatric neurosurgeon, ENT, and plastics. The goals of the collaboration were really threefold, as listed here in discussions with the team. One main priority is just boosting clinical capacity, so through local support and expansion of surgical subspecialty capabilities, in particular, complex urology and oncology, and also pediatric anesthesia. And there's an interest in creating a minimally invasive surgery access as well. Currently, they do not have any laparoscopic equipment, and I think they're exploring possibilities, and the feasibility of this will really be instrumental to have US support and regular teaching opportunities. In addition, there are many rural outreach programs, so the team goes into the periphery and provides a lot of education for local surgeons and direct clinical care, which can be very onerous with how busy UTH is. Supporting the training program through teaching and mentorship, of course, and support of their academic and professional goals. And then finally, expanding their clinical research capabilities, in particular, creating patient registries so that they can study the outcomes in the tremendous volume of patients that they are seeing. So you're going to hear a lot more from Dr. Ngola shortly. And I don't know if I can play the video from here.
Good afternoon. My name is Amon Gongola. I'm a consultant pediatric surgeon based in Lusaka in Zambia. with Dr. Bruce Folani and Professor Mukonge, who were the first two pediatric surgeons in the country. And so far, the program has graduated 9 pediatric surgeons, me inclusive. The goal, as currently we have, like I said, about 10 in training in different years of study. The goal is to graduate at least 2 or 3 surgeons every year in the next 15 to 20 years in order to cater for the need. This graph is just basically showing us the patient volumes, and we do at least 1,700 cases per year in UTH. We also do outreach currently to at least 5 sites. Yeah, so in terms of the scope of cases, this is just as of 2023. And this is just a graph from 2019 to 2021. And we see the number of cases increasing across the board. Yeah. Some of the limitations we have is just inadequate pediatric anesthesia staffing because we have very few pediatric anesthesiologists, but we use the general adult anesthesiologists, and we have a few pediatric anesthesiologists currently, 4 in total for the entire country, and we have 2 also in training through the Pediatric Anesthesia Training Initiative with the anesthesia colleagues. But the other challenge is also critical care. If you do a serious major cases, you need some support with regards to post-op care and recovery. And we end up counseling some patients because we don't have sterile gowns or have run out because of the volume, the sheer volume of patients. So on average, we operate 3 times a week, and our lists would range between 10 and 15 patients. And so sometimes you run out of consumables, things to use because of just the sheer volume of patients. And obviously we see quite a number of delays of patients who present to us, some of them with tumors that have grown significantly in size, and that makes surgery technically more difficult. And the lack of surgical capacity in the rural areas means that if the child presents with, say, an anorectal malformation and there's no one to do a stoma, for example, it means they either have to travel long distances to reach our center, or they may just die in the rural areas. We have long waiting lists for some of the patients, so we end up having children who are now maybe 6 or 7 years old with an anorectal malformation still, either because they are lost to follow up or something, but they're on the waiting list for us to do an anoplasty on them. Well, there are opportunities, obviously, for collaboration, and APSA is a great partner for us when it comes to support with training and support with mentorship. I think it brings a lot of weight on board for us. So there are great opportunities. One of the areas that we'd like to see is improved training and also outreach services, and training for staff that are out there in the rural areas who are the first contact with some of the pediatric patients that we see. I think this is an opportunity as well to sort of build capacity in the peripheral hospitals. As a team, we have continued to do our training. We have currently the same 10 pediatric surgeons who are now faculty training other pediatric surgeons. And this is an important milestone. We're doing everything we can to continue providing care because we believe every child matters.
Okay, it is my absolute pleasure to talk about the experience in Hawassa, Ethiopia. I just returned from spending a month there and will share my experience. So Hawassa is in the Sidama region of Ethiopia. It used to be part of the SNNPR kind of conglomerate of tribes there, which was recently separated into individual tribal regions. And so now is the Sidama region. The hospital there is a referral hospital for the entire southern area in Ethiopia, and it's about a 400-bed hospital. The residency program there, the residents are excellent. They There's 9 residents per year, and they spend 4 years training after their 2 years of general practitioner experience, similar to an internship. And there are 2 full-time pediatric surgeons now there, the second of which was just recently hired in about 9 months ago. And both are excellent surgeons. Each day there's about 3 to 5 ORs that are functioning. They're currently functioning out of a temporary annex building while the original ORs are being rebuilt. So there will ultimately be 11 functional ORs with 2 dedicated pediatric ORs, which is very exciting. I think that's about a 6-month process away. In terms of pediatric cases, they operate on Tuesdays and Thursdays. And there are 2 full-time anesthesiologists. They are not specifically trained in peds, but they are trained in anesthesia, and there is an anesthesia residency. And the surgeons also work with a nurse anesthetist, depending on the patient and the case. It is certainly a very low-resource setting, and the number of cases that's able to be done is limited by all the resources, be it gowns, gloves, suture material, and personnel, nurses and anesthesia, et cetera. Hawassa is a lovely place. There's amazing Ethiopian food. There are monkeys everywhere. They're like the squirrels of Hawassa. You'll see people traveling in donkey carts and working that way. You get around by Bajaj. That's how I got to work every day and back. There are hyenas. I don't have a picture, but at night you want to be in an enclosed vehicle. Coffee is really important in Ethiopia and delicious, very strong. There are these little coffee shops along the road all over, so there's never anywhere you won't be able to have a cup of coffee if you want one. And then all over Ethiopia, there's construction, and these are the scaffolding that they use for construction. Currently at the hospital, the collaborations that are ongoing, there's a German nonprofit that's working with the pediatric surgeons there, and they are funding the building of those 2 dedicated pediatric ORs, and they'll be equipping those ORs with state-of-the-art equipment. And they're also going to be helping to equip the NICU with 6 dedicated surgical beds, and they will be contributing a ventilator. It does look like it's about 6 months until those will be up and running. They've made a lot of progress in the last 6 months. And then the ACS collaboration, which has been ongoing for several years. There was an initial focus on trauma, and they did a lot of work in the trauma realm initially, and then more recently brought a 5mm laparoscopic set and started training in laparoscopy with laparoscopic cholecystectomy. In terms of the APSA collaboration, the first pediatric surgeon to visit from the US was Dr. Manish Raji. And then my visit was the second, since COVID sort of interrupted things. Limitations at the hospital. The Ethiopian government currently is not supportive of the healthcare sector, so financially there's not much money. They have been approved for a pediatric surgical fellowship, but that funding is on hold. All of the healthcare staff are underpaid, including surgeons. They do not receive a living wage. And there's an unreliable supply chain. In terms of patients' coverage, insurance is really not useful. Although it does exist, patients are paying out of pocket. And there is an active conflict ongoing now between the Oromo and the Amhara regions. There was a Tigrayan war that has resolved, but there's now skirmishes to the north of Addis. My experience was wonderful. I was working very closely with Dr. Wande and Dr. Shagre, who will meet on the video in a second. They are both excellent surgeons. And so I spent my time assisting them operating. I attended their referral clinics and helped in referral clinic to some degree. And then I took call and was able to work with the residents overnight and round in the morning. In terms of teaching residents, it was a great opportunity. They have lectures every Wednesday morning. I was able to host a sim lab with the laparoscopic training boxes they have, and operating with them overnight and coming in to see consults overnight. just contributing my perspective to their education, whatever that was worth. We also started some research work, which I had started from afar before I arrived, but we made a lot of progress designing a NICU quality improvement project and organizing a retrospective review of their Hirschsprung's disease cases. The schedule is morning report 8 a.m., and then pediatric surgery lecture every Wednesday at 9. OR start around 8:30. There are 3 to 4 scheduled cases per day, and then referral clinic on Wednesday and Friday. Most afternoons were free, and then I took calls overnight and would come in occasionally when needed, and then arranged some research meetings overnight. Here's another picture of a Bajaj, just how I got to and from work, and then the children that were going to school every morning on my way, and then this is just an image of the morning report session and the OR. Challenges. There's intense poverty all around, and so emotionally it did feel very heavy to be there. And the pace was slow, so I had to adjust to that. There's a 3-year wait list for children in need of elective surgery, and a lot of those cases are awaiting pull-through or PSARP. And there's just not really much ability to increase that caseload as a result of me being there, just because of those limiting factors I discussed: OR time, anesthesia, nursing. And then the fact that patients have to come up with the money to pay for their anesthesia drugs and their suture material and everything before they can go to the operating room, even if it's an emergent case. But I think it was a successful trip. We made a lot of progress on the research, just developed a multidisciplinary resident team to address the NICU Quality Improvement Project. We did perform 3 laparoscopic assisted pull-throughs, and those were the first laparoscopic cases that were performed in Hawassa for kids. And we organized a sim lab, which the residents really enjoyed. And then I learned the system, and residents started calling me for help, and I was able to show some new techniques. There's me and Dr. Wande operating. Well, Dr. Wande's operating. He did the entire 3rd case himself. It was a natural. And then there's an image of us working on the sim lab. Goals for this collaboration are really knowledge and skills sharing. This area of Ethiopia has so much anorectal malformation and so much Hirschsprung's disease. I think there was a Hirschsprung's admission every single day I was there, probably 5 babies a week with imperforatus. So it is incredible, the volume of colorectal pediatric surgery. And Dr. Wande would like to develop a center of excellence for this, as well as pediatric urology. And then the residents and attendings were very interested in laparoscopy and learning laparoscopy. So I think that's a really, that's something we can contribute. As well as bringing material. So I brought 2 duffel bags full of stuff, and that was very useful. Introducing a new perspective, kind of different techniques. How I do things is a little bit different than how Dr. Wande does things, and the residents can benefit from those various perspectives. And then this is an opportunity for US and Canadian surgeons to participate in a program that is sustainable and capacity building, and so that's an awesome opportunity as well. So here's this video that we made. Also a picture of a hippo. The lake is beautiful, but there are hippos, so we can't swim. But this is a video, and you'll get to meet Dr. Ashagre and Dr. Wande.
My name is Wandamagin Gazal. I am a pediatric surgeon in Hawassa since 2016, 2017.
Well, my name is Dr. Ashagre Mikhail, and I'm a pediatric surgeon.
Hawassa is a small town south of the capital, Addis Ababa. It's about 270 kilometers situated south of the country. Hawassa is a very beautiful town in the country, and the weather is mild, and it has a lake that is close by.
You know, pediatric patients in this country in general, they almost encompass half of the population, which means now currently we have 110 million population, which is estimated, and nearly half of them, they are under 14 years.
Hawassa is supposed to provide services to most of the population south of Addis. This has a catchment population of about 20 million.
Pediatric surgery in our country is a very recent development, and until recently we have only very limited centers. As you can see, we have only 2 surgeons here and single surgeon practicing for the past 5 years. We see almost every case.
The most common ones are Hirschsprung disease, then anorectal malformation, hypospadias, and other emergency cases like intussusceptions and neonatal obstructions, and more rare cases are also there. The plan is in the future to have standardized and better care providing facilities so that we reduce the mortality, morbidity for our kids. APSA will be very integral to our future plan of establishing pediatric surgical fellowship and training these new fellows in equipping them with necessary knowledge and skill. Experienced pediatric surgeons would come from the APSA and teach the residents and in the future the fellows, and also transfer very crucial skill to us, to me, like minimal invasive surgeries, advanced surgeries that are never done here, in the future will be done.
When we have these collaborations, there is a big chance of even exchanging technical skills and experiences from APSA. This is a place where there is a potential to grow or to train more surgeons. I mean, I would like to thank you. Yesterday we did a great job with our first experience of doing this laparoscopic assisted surgery. So Dr. Heron helped us a lot, and I'm thankful, and I will see you in the future showing me a lot of things. That's all. Thank you.
So in terms of the logistics of volunteering, now that you've seen the incredible need, incredible opportunity, both in Ethiopia as well as in Zambia, what we are looking for, again, we're augmenting the partnership that has already been established with the American College of Surgeons. And so, you know, as Heron kind of showed, just that being present, and so the ideal would be 2-week or 4-week blocks. Again, this is volunteer, so getting the time away can be a challenge. We don't want to disrupt the local structure of the week, the training program, so we really want it to be able to integrate. And again, anticipate being part of the team. And so that integration into the local workflow and education structure can be a little bit slower, but really has that potential to build in. And then our local partners, you know, along the way will identify some high priority programs or lectures or patient populations that they can kind of cohort. And both sites are a bit different. Dr. Wande's really identified colorectal as being his area where he wants to focus. They do a little bit more with some neonatal and oncology in Lusaka. But again, I think that it's really taking that time to listen to our partners. We would ask that anyone wanting to volunteer, particularly as we get started, that we get 6 months in advance to really coordinate with the American College of Surgeons and the team. Just as a reminder, this is a volunteer opportunity, so APSA holds no legal ramifications. It's really providing that opportunity, listening to the membership to say, hey, we want to get involved, we want something sustainable, and using the work that the American College of Surgeons has done with incredible local logistics, partnerships, any of the partnerships with the local hospitals, surgeons, ministries of health are through the American College of Surgeons, and so we partner with them. And then as a committee, our goal is to help mentor, orient, and then get feedback to make the program better. And so there's 3 QR codes up here. The first is for the Global Pediatric Surgery Committee, just to kind of review activities, review our mission. The ACS Hope Collaborative, if you want to learn more about the background, see some of the updates, that is there. The email sign up is a direct email to me. So if you are interested in volunteering until we get a better system, send me an email. It's even templated if you go directly to that QR code. Not too much spam would be appreciated.
Thanks. We have about 6-7 minutes left. I just want to give everyone in the audience an opportunity to ask any questions that you might have.
I'm supposed to be monitoring the chat, but there are no chats, so I'm going to ask questions. Eric Hansen from here in Phoenix. Thank y'all. I have an idea of logistics and all the work you put in, so thank you. Logistical questions based on my own personal experience and other people's. One, what's the medical legal cover for things that happen in country when there's a lawsuit? Again, personal experience. Number 2, ACS or APSA, you talk about logistics. People have asked me before when they've come and helped me, tax-exempt donation type options, such that does ACS or does APSA have a mechanism, since they're both not-profit organizations, where I can donate money that can be used for my travel, my accommodations and whatnot, that would then be nonprofit tax exempt. And so those are, I say I'm using the generic, because those questions have been asked of me when people have come and helped me before.
Answering the second one first, I love that idea, but I don't know that that has been set up. And I think logistically, that idea would be something that we'll feed back to the college, because essentially the universities that are partnering are each paying about $5,000 a year, and that's helping with local accommodation and coordinator. APSA members won't pay something separate. We'll get the benefit of that. Within the memoranda and the agreements with the local hospitals and the college, any of the medical legal is included in that, I believe. But that is something that's part of that agreement. And so APSA is not directly negotiating with the countries or the hospitals, which is why we're going directly through what ACS, they have several coordinators kind of working through, and that's why it's taken 5 to 10 years to get all of the agreements. But that is something that is that has gone through all of the universities partnering and their legal. In terms of your own personal insurance, and that is on behalf of the volunteer. So if your own institution supports it as time away, you can sometimes get that covered. But I love the idea of the donation and that. And I'll just plug for the committee that one of the other activities is the research scholarships that are being given directly to LMIC researchers. And so if you are looking to be generous, go to the APSA Foundation website. You can donate. You can also just specify global, and it'll go directly to those scholarships.
Do you want to, Dr. Cleary and Dr. Baumgarten, do you want to speak to what you do on the medical legal front? I can a little bit speak. I haven't gone to these 2 sites. I go to a different location abroad in a low-income country, but it's amazing what your institution will give you if you just ask. So mine, actually, they will cover my malpractice when I'm abroad, and I don't come from an institution that has a huge infrastructure necessarily for global surgery work. So, but let me let you both speak.
Yeah, there's limited coverage through UMass. They require that you apply and get coverage before travel and register all the travel. And I believe ACS has coverage as well. And by virtue, APSA members should as well through the MOU. The medical licensing, so the temporary medical licensing process is also kind of part of what we're trying to streamline and facilitate. So, it involves sending all the appropriate documentation and licenses and certificates to the ACS offices, and the Ministry of Health has agreed to waive some of the fees. Because in Zambia, I don't know what it is in Ethiopia, it's quite expensive. It's like over $600, and it's only a 6-month license. So that part has been facilitated.
The licensing was very easy for HWASA. I sent them my CV and a letter of good standing and my diplomas from medical school and residency, and then they licensed me, and it was free. And that was all through the ACS website. But that's a very streamlined process, very, very easy. In terms of malpractice, I probably should have asked more questions about this. This is my first experience going abroad. I have it written into my contract that I'm doing this, and so I hope that means that my malpractice covers me, but I'm not really sure.
Hi, my name is Kathy Cosentino. I'm from Tucson, and it's obviously difficult to practice in an area that is so has such kind of limited resources for you. And when you look back on your experiences, when you do these trips, you want to feel like you've accomplished something. What do you feel were your biggest accomplishments in each of these 2 places that you visited?
I can go first. So my trips have so far been pretty short. I've spent 2 one-week trips that were mostly needs assessment. So really speaking with all the trainees, sitting with all of the consultants, and figuring out their workflow and where the gaps really are and where we can help to fill those gaps. And the most recent visit, I did some direct clinical care and some teaching in the OR, but I think the biggest contribution I've felt is helping with the trainees. So helping with education, helping with didactics, and providing some guidance with all these research questions that are just bubbling to the surface. There's so many things that they want to study and share, and I think that's where we can play a major role.
Yeah, I also felt like my progress with the residents and the surgeons, as well as neonatologists there, was the progress on the research was really good. I think we have the outline, and we've started work toward a really solid proposal for a quality improvement project that I think will really help babies in the NICU. And then introducing laparoscopy and showing them that they actually have everything they need to do those cases. And also the skill to do them, I think was great. And it really, I saw that they were very, very excited and inspired by that. So that felt good.
Great, thank you.
Jerry Obey from Phoenix. Thank you so much for such a wonderful talk. I think this is great pathway for some of us that are interested in volunteering. And I just remember just thinking, just logistically, how do you do this if you're not going to be doing it like a full, long-term commitment? And I think there's a lot of interest, and this is a nice pathway that you guys are kind of help create. A few questions. One was about Heron, you were saying that when you went there, you went with 2 duffel bags. Were you scrounging for supply, sutures, equipment, Lone Stars? I mean, what and how did you figure that out? That's the first thing about that. That's one question. The other is about attitude. What did you find was it the appropriate attitude to have when you go to these places that, you're there only for a very short period of time as a volunteer. And so you're not gonna, and so there should be a certain, I assume, an attitude that you feel it was helpful, that the locals are gonna, that the actual staff that are there, they're there long-term, that they would, felt like they would appreciate and worked well with them.
Great questions. Yeah, I just scrounged the OR for stuff that was near expiring or stuff that wasn't being used, and just tried to find stuff to bring that was going to be helpful, and had OR staff kind of helping me over the course of several months beforehand to put that stuff aside for me. I'm sure there's a better way, and actually I was able to get almost everything through. but certain things will be stopped, and then there was one thing I had to take home. So, in terms of an attitude, so I've wanted to do this for so long, and this was my first experience. So I really wanted to just kind of leave expectations behind and not really come with an agenda at all, but to just see how can I be helpful, what is the need, or maybe I'm just a warm body, right? But maybe there's more. So I think it helped to establish a little bit of work beforehand on the research projects, on the research side, figure out which residents are interested, and kind of start that collaboration beforehand, although not a lot of progress happened from afar, but at least that had started. And then I just had to really check my own, even though I really tried not to come with expectations, it was hard for me. The pace was so slow, and I felt like I was surrounded by all this poverty, and I really wanted to do something about it, and I couldn't do anything. It was hard. It took some time to adjust to that. But to really try to keep that in check. I did not want to be a burden at all to the surgeons there. My presence, I really just wanted to be a positive thing, and so I just tried to find the opportunities I could. It felt really good as the residents started to kind of maybe trust me or be interested in working with me, that they were calling me more over the span of the time that I was there. I felt like that was positive. A lot of positive things sort of evolved over the time, but I just tried to be very open and just figure out the opportunities that were there, and take those opportunities without forcing my own agenda.
I really love both of the questions because I think it really gets at creating an opportunity for people that may or may not have been involved before. And one of the goals in the program is really that we're helping to get the feedback, so providing some pre-departure, some return, mentorship, debriefing, et cetera. The same as what places will set up for visiting trainee, and evidence shows, for trainee rotations and things like that, that we feel that the people that are going really deserve that, so you can reflect on it, and be as responsible, as a program in who we're sending, and how people are incorporating. And both sites and partners are incredibly enthusiastic about the people that are coming, and the teams that are coming, and so they're also a huge resource. And we're augmenting what the college is doing, and so they're having teams that are coming, individuals and/or teams that are coming every few weeks or every month, and so they're also a great resource with that exchange there. Materials in that the College and Each Collaborative is setting up, and there's work groups that are working on ways to send larger donations, to partner with industry, et cetera. And so there's a lot of opportunity for that too, but again, that's leveraging the larger partnership for some of that too. So really fantastic questions.
We're out of time. I want to respect everyone's time, and thank you all for coming here tonight. I hope this was informative. Please use the QR codes. We look forward to interacting with you and hearing from you.